everyone. So this is Dr. Stefano Bertozzi, he's the Dean of Public Health here at Berkeley. He did his bachelor's in biology at MIT, followed by an MD at UCSD and a PhD in health policy and management at MIT. He's worked with the WHO, UNAIDS, the Mexican National Institute of Public Health, as well as served on the advisory board of the Emergency Plan for AIDS Relief, NIH Office of AIDS Research, and the WHO. And more recently, he's worked with the Gates Foundation on the HIV and TB programs, and now he's the Dean of Public Health. So,
thank you. So, since we're not very many, I'm actually happy to talk about whatever you guys want to talk about. I have a few slides here, and I just stuck a last few slides on there about how the Gates Foundation makes decisions about what it wants to invest in. We can talk about that. I have a slide at the end about how many of you are familiar with the Institute for Health Metrics and Evaluation? Played with their website?
All right, you talked a little bit about, I heard your presentation at the Global Health Conference that you get back in the fall.
Okay. Right, exactly. So I talked about it a little. So we can play with that as a way to think about how you might prioritize what you want to work on in the molecular diagnostic space. And what Amy had talked to Valdemar about is looking at a few examples of extraordinary heterogeneity in performance once things get into the field, and the degree to which that is or is not determined by characteristics of the device versus characteristics of how it's used. And the examples that I had used to illustrate heterogeneity for a different discussion are actually ones about diagnostic testing. So we could start with that. But I'm serious, I'm incredibly flexible, just a few of us. So I really would like it to be a dialogue. Stop me, interrupt me, tell me to move forward quickly, whatever you guys want, okay? So I'm using a few slides here from Mexico, and I'll show you a couple other slides from the US PEPFAR program. This was just showing you where the sites were, but what this suggests here is that HTC is HIV testing and counseling, PMTCT is prevention of mother-to-child transmission, and the cascada de atención is the care cascade in terms of, if you imagine that in the case of prevention of mother-to-child transmission, for example, you've got a woman who is HIV positive and pregnant. That woman needs to get identified as HIV positive, so first HIV testing, and then that test probably needs to be confirmed. And that confirmed test needs to probably have a CD4 count done, because in most places that determines what kind of prophylaxis she would get, whether she would start on treatment for her own HIV infection. So that requires a CD4 test, and the results of the CD4 test have to get back to her, and then she has to make the decision to accept the treatment. And then you get down to the end, and you have the number of women who are HIV positive and who are effectively treated, and some of those fail, and in fact anyway transmit to their kids, and then you do it again when you're talking about transmission through breastfeeding. So this is just an example of some variability from place to place, Kenya, Rwanda, South Africa, Zambia, in terms of the cost. And what you see here is that, can't see very well, but take a look at Rwanda, and you can see that the light blue bar is, excuse me, the cost per client tested. So it's what, $5 there, right? And the cost, that's a log scale, so the cost per client tested and identified as positive is $1,367. So they're testing a whole lot of people to identify a relatively small number of positives, which is why the differential is so big. While in South Africa, not surprisingly, first of all, it's much more expensive to test every individual. I mean, the cost of the test should be the same. The salary costs are much higher in South Africa. It's 10 times as wealthy as Rwanda is. But the HIV prevalence is much, much higher. So you've only got, whatever it is there, it's about a 6-to-1 ratio. While on the other one, you have this enormous, whatever it is, 300-to-1 or something ratio. in terms of the cost per person positive identified versus. And if you're doing this to find positive people, then it turns out that even though labor costs are 5 times higher in South Africa, it's a tenth as expensive to identify a positive person in South Africa than it is in Rwanda. So if you're thinking of, if you're, PEPFAR, and you're thinking about where you're going to spend your marginal dollar on testing people, you're much better off testing in South Africa than you are in Kenya, and to the extent that you don't have full coverage. So that's just one sort of, things are different in different places. This one I stuck up there. These are the same 2 things in the middle as male circumcision, because they also looked at male circumcision. It turns out there's a little bit of diagnostic use in male circumcision because some countries, some programs will not perform free male circumcision on men who are already HIV infected because there's no evidence that it reduces transmission from the infected man to an uninfected spouse, but it's probably about 70% protective for men to be circumcised. So the uninfected man stands to benefit much more, society benefits more from the circumcision of an uninfected man. So some programs will circumcise you regardless, some programs will only offer circumcision to uninfected men, and either way, somebody should know, and therefore they're often offered testing. But ignore that for a second. What I thought was interesting was looking at the other 2, which is, this is just counseling and testing of people in the population to find out whether they're HIV infected or not, mostly for the purpose of starting therapy. And this is prevention of mother-child transmission, identifying positive women to prevent transmission to the child when pregnant. And I put a red bubble on the part of the bar that is supplies. So you can see, first of all, it's a variable size of the bar, and it's not surprising. Rwanda is significantly poorer than Kenya, so all else being equal, you would expect the cost of supplies to be a higher proportion in Rwanda than Kenya. But the more important thing, I think, is that, look here, this is PMTCT is mostly about finding positive women, and yet the cost of supplies is a relatively trivial part of the total. So even if we reduce by 50% the cost of the test, we wouldn't necessarily significantly affect it. Of course, that's very different if you're talking about a place like Mexico where you're testing many, many, many more women to find a positive woman. This is just an illustration of the fact that, first of all, people think of AIDS in Africa as if AIDS is carpeted with, Africa is carpeted with AIDS. But in fact, Washington, D.C. has higher prevalence than most of West Africa does. It's highly heterogeneous within the continent. It turns out it's like a fractal. Every time you focus in more, you still see this extraordinary heterogeneity. So you see it within Tanzania, you see it within districts within Tanzania. And this, if it works, is a pretty remarkable statistic. So Kenya, early country affected severely by HIV. I mean, it's got one of the oldest epidemics, not quite as old as Uganda, but they're neighbors. So it's a very old HIV epidemic. And what's pretty incredible here is that half the sites in Kenya, this is prevention of mother-to-child transmission, where they test all pregnant women. Half the sites in Kenya last year detected 0 women. And 28% of the sites detected 90% of the women. So within Kenya, you have this extraordinarily heterogeneous distribution. And why was this really important was because up until last year, they've been more or less distributing resources equally across the prevention of mother-child transmission sites. So you have sites here that have lines around the block and can't take care of the women that they're finding, and it's incredibly efficient to test here. And you've got all these sites where they're getting no value for their investment.
So if you were to provide the government with this information and they wanted to action on it, so what's the lag?
And they have. So this is good.
So, yeah, so what's the lag in sort of the feedback to redistributing the resources?
Well, that's a good question for Debbie Burks, who just presented this, but since much of this money, in fact, comes from PEPFAR, which is the President's Emergency Program for AIDS Relief, there's a lot of leverage in this particular case. And I think there's been very significant redistribution of resources. But in general, it can be really hard, depending on what resources you're talking about. So redistributing test kits is really easy. So I was just in Mexico a month ago, and exactly the same issue with respect to glycosylated hemoglobin, hemoglobin A1C. It's when the glycosylation of hemoglobin is related to the level of glucose in the blood. So What that means is that you get it's like a smoothing of blood glucose. So you get a long-term picture of the level of control in somebody's glucose levels. So it's a really useful tool for monitoring how well somebody's glucose is being controlled, because it's not just a spot check of that momentary blood glucose, but rather a smooth version thereof. So everybody in Mexico with diabetes is supposed to get their hemoglobin A1C checked. And in fact, they found that 16% or something of patients in the primary care level were getting their hemoglobin A1C checked. And that the distribution of test kits was basically uniform, not taking into account the variability and demand at the various testing centers. And the other problem was that, of course, many of them didn't have the capability to do the testing. But so this issue of, it's amazing to me how people routinely just sort of assume homogeneity. And the reality, if you go and look at it, is just so far from true. I mean, you might think that being one of the oldest epidemics in the world, that this would be an epidemic that would starting to look relatively homogeneous across the country. And it's so far from being true, right? I mean, it's just orders of magnitude difference, between different parts of the country.
So was there any sort of...
I'm sorry.
I was kind of curious, now that the government is aware of this is going on, was there any sort of like sophisticated model or anything to determine how to redistribute and how many kids different clinics could have and staff, or like how is that determined once it was sort of identified that there's this mismatch?
That's exactly what the head of the program says that she's working on now, is what's the more intelligent distribution of resources, right? And because what's the next step? The next step is to look at performance across these sites, right? So is it true that, it's likely to be true, but the next step you need to show that it's true, that these clinics here are in fact failing in terms of prevention of mother-to-child transmission because they're overloaded, right? So the question is kind of what's the sweet spot? Clearly you want to redistribute away from these clinics and make sure that you're not overburdening, that you're relieving the overburden on these clinics, right? And that everywhere there are, supply chain issues and those kinds of things. So this is just looking at the costs, and this is cost per client served. In this case, voluntary counseling and testing on the top two and PMTCT on the bottom two. This is the cost per client tested, and this is the cost per client tested and found to be HIV positive. Now, what is remarkable here is, first of all, not that there is some indication of a relationship to scale. You would expect that large clinics would be able to test patients more efficiently than small clinics. And there is some relationship to scale. But what's remarkable is the degree of spread vertically at any particular scale. This is another law graph, right? So you're talking here, blue is a single country, this is Rwanda. And you've got everywhere from $3 to $100 per person. So a huge amount of variability. And why? Well, in the case of voluntary counseling and testing, why do you guys think that you've got lots of vertical spread there? Any idea?
People, for whatever reason, some populations may be less likely to get voluntarily tested, or may not know that that's an option.
Well, this one is per client tested, so this is independent of prevalence. So here you see it as a function also of prevalence, because this is the cost per positive person identified. This is just cost per person tested. I mean, it's, you might imagine that it's things like, well, this is cheap because this is an area with low labor costs, and this is expensive because it's an area with high labor costs. But it turns out that the blue one is a really small country. It's like saying there are high labor costs and low labor costs across Connecticut. So it turns out it's really just a question of management. I mean, there aren't any obvious explanatory variables for why this was the case. I mean, we found 2 orders of magnitude difference across Mexico. And people say, oh, but the rural areas are much more expensive, hard to get to. Yeah, but all the clinics were in urban areas. And well, there are higher labor costs in the South than the North than there are in the South. Yeah, but that's 20%. It's not towards the main. It's revealing the heterogeneity can lead to extraordinarily important responses in terms of responding to the inefficiency that people observe. Because somehow these folks are doing it for $3, right? So it's $1 worth of a test kit plus $2 worth of labor, and they're somehow making it work. Now, you might think, oh, well, it's quality differences. Well, this is a pretty standard protocol implementation. So, in this side, you would expect to see more because of the variability in prevalence. And there, the question of where are you undercovering the population? So if you've got 50% coverage in 2 different areas, and one area has 4 times the prevalence, then you're much better off getting much higher saturation in the areas with higher prevalence. This is just another representation showing this is sort of the production possibility frontier, sort of like this is how efficient you can be because there are clinics at that level of efficiency, and everything above the line is the money you're throwing away, unless you've got some other good explanatory variables for why that might be the case. And I just wanted to sort of mention, here we're talking, it's actually an interesting graph too, just before we go to the diagnostics. So this is a slightly different version, and this is now treatment, okay? So this is identifying people for treatment rather than prevention of malaria child transmission or just HIV counseling and testing. So this one is what proportion of the clients in this clinic, when they were first tested and started on treatment, had a CD4 count above 200. So I don't know how much you guys have been following, but what happens with HIV infection is that you have a steady decline in your CD4 count. People with normal immune systems have 800 or 1,000 or so, and progressive decline. When you get to 200, you start to get very serious life-threatening opportunistic infections. You can get tuberculosis and a few of them higher than that, but 200 and below, it's really bad. 100 and below, it's really, really bad. And 50 and below, it's really, really, really bad. So the idea is that nowadays, the guidelines in this country start people at 500 or above. There was lots of controversy. Most countries are using 350. Everywhere should be starting people above 200, because below 200, we can go into it, but there are many, many reasons why it's a really bad idea. So this is the proportion of the clients in that clinic who started antiretroviral therapy above 200. So it should be 100%, okay? And here you've got clinics that are 25%. So in other words, 75% of patients fell below 200 before they started therapy, which means they were severely symptomatic with AIDS. 200, by the way, is an AIDS-defining level. So you go from HIV infected to AIDS when you cross that 200 threshold, or when you develop a serious opportunistic infection. So you want people to be out here near 100. And this is the cost of treatment, and having to do with the fact that you've also got lots of complications when you get below 200. Now, this is the same thing, except instead of being, did you start on time, this is, was treatment successful at suppressing your viral replication? So this is with undetectable viral load, okay? So this is the variability in cost, and this is the proportion of patients who have undetectable viral load. So in the best clinics in Mexico, it's up around 90%. But there are clinics where 75% of the patients don't have their viral replication suppressed. So you've got huge differences in performance, and as you might imagine, higher costs associated typically with the clinics where you're uselessly treating 3/4 of the patients, right? As opposed to the clinics where you have many patients effectively treated, where the cost per patient effectively treated. And this third one is both. Did you start on time no, so it's even one more step complicated. So one of the problems with starting late is that your ability with effective treatment to recover your CD4 count to safe levels is correlated with how late you start. So if you start later, you're less likely to get CD4 recovery. And you've got people who start at 25 and never get above 200, and so they're much higher mortality. So this is saying, did you actually succeed with this patient? So did you get them virally suppressed, and did you get their CD4 count back up over 400? In other words, that's a patient who's effectively treated. And you can see there the variability in cost per patient. You know, you've got some clinics that are achieving a patient successfully treated for $6,000 and other ones that are closer to 60. So huge variability in performance on those two axes. And I just, to relate it to you guys, you're using just simple rapid diagnostics for HIV to identify people on time, right? Then you've got things like the ALIR PIMA test, which is point of care CD4 diagnostic. ALIR hasn't yet, they put out there whatever it's called, ALIR Q, which is the precursor to point of care viral load, but they still haven't started marketing the point of care viral load. That's the point of care antigen detection for for infant diagnosis. So it's a step function PCR, but it's not a quantitative PCR. And I don't understand why. I mean, they were showing us examples of it 2 years ago. So it's taking a very long time to come to the market. And then just stick the PIMA there again, because over here it's a combination of viral load and CD4 recovery. And here's the way the clinics in Mexico stack up. And just a different form of graphical representation. Here you can see the proportion of patients who start on time. And this is remarkable because in most medical systems, the people who run medical clinics, they think of their responsibility as dealing with the incoming patients. Like, you walk through the door and you're my problem. This is a problem of the clinics not going to the community and finding the people who aren't walking through their door. You know, this is a clinic that has, whatever it is, 18% of their patients start on time. So in their community, they're doing a terrible job of getting the patients in on time. This is the percentage of patients with viral suppression. And you can see that the best ones approach 90%. The width of the bars is the number of patients in the clinic. So the big one in the middle is Mexico City. You can see Mexico City does relatively well with respect to getting people on time. There's much more testing in Mexico City than there is in much of the country. And they do kind of middle of the road with respect to viral suppression, so clinical efficacy. And this is a little bit worse still in terms of viral suppression and CD4 recovery. And here's the map that I want to go show every clinic, because they can see themselves on here. The bottom one is whether they start on time, and the vertical one is whether they're effectively virally suppressed, and the dotted lines there are the medians. So you can see that they don't do so bad. I mean, they should be up at 90%, and nobody should be below 80%, but at least the median is not so bad with respect to clinical efficacy. So they do better, relatively speaking, with the patients that come through the door. They do terribly. Median is only 50% of patients starting on time, and on time meaning more than 200, while the norm, even in Mexico, the norm says start at 350. So the proportion who actually start when the norm says to start is much worse. And it's just kind of depressing when you look at where people should be. Right? I mean, if you think that, 75% or better on both axes is where you should be, you're up in territory that doesn't exist. So I'm actually going to Mexico next week to talk to the HIV Congress, and what I want the ministry to do is to show people this graph, but tell every clinic where they are. I know which one is Mexico City because it's big, but I can't tell you any other one. And they look okay. Not great, but certainly okay compared to, you got clinics down here, it's pathetic.
So what do you see as the primary differences between clinics that are performing well on this versus clinics that are performing poorly? Are there any sort of standard differences that could be applied, or?
That's obviously the next question. And it's one of those things, again, where I think you'll find that it's purely a performance, human resources performance issue, and not, I mean, sure. Well, is this affected to some degree by supply chain? Yeah. Is this affected to some degree by some states, provide more resources than others? Yeah, some, but nothing like that. I mean, overwhelmingly, this is just bad practice in medicine combined with bad patient engagement and bad adherence support and bad social services or whatever it is. But it's not like, you know, you're talking, it's not like one of these things where the Beverly Hills clinics are the upper right-hand corner and the, you know, Roxbury or East Oakland clinics are down in the lower left. This is all heterogeneity. This is not even all the different types of clinics in Mexico. This is only the clinics managed by the Ministry of Health. It's not the Social Security clinics, it's not the private clinics. This is just one system worth of clinics. And all in, this is free antiretrovirals to anybody who comes to these clinics, national program. So it's mostly, in other words, it's mostly inexcusable heterogeneity. Now, I find it easier to think about why this axis is variable, because in some ways that has much more to do with what the clinic would say is not its job, which is community outreach and whatever. I mean, some places the clinics feel like it's their job. Mexico City certainly does. But the woman who runs the Mexico City clinic also runs the AIDS program for Mexico City. While in many of the other ones, that's not the case. It's a doc who runs the AIDS clinic and doesn't necessarily see their responsibility to do community outreach. So, go ahead.
I think that might explain too why it seems like for the worst performing clinics on that axis, there seem to be more of the kind of middle size.
You know, somebody was saying that to me yesterday, that why is it that it looks like it's the little clinics that are in the lower right-hand quadrant and to some degree in the upper left-hand quadrant? I don't know if it's, if you took two of the middle clinics out, you wouldn't say that. And, you know, is that real or not? I don't know. I mean, I asked the same question when I look at it. I don't know. It's incredible to me that a clinic that big, it's not that big, but it's a relatively big one, could perform that bad without anybody paying attention to it. I mean, it's the kind of thing where I want to show it to the patient so they can start marching in the street. Because, you know, 30% suppression rate is scandalously bad. That's 70% of people dying with completely ineffective treatment. And that's what we saw in the prisons when I went into the prisons. And now the prisons are way better. Prisons are, in fact, like the upper right corner now. Welcome to Mexico City. So the question is, what do you do with this? Now, if I take the same, first of all, I show them this graph, and which says, you know, people are really different. But now, if you're going to go and work with a clinic, they don't actually want to know what this graph says. They want to know, because it's not really fair. The current director of the clinic needs to know what is the percentage of patients who initiated ART with a CD4 count of more than 200 last year. Because this is cumulative for all patients, right? Because you get this characteristic once at initiation and you keep it for the rest of your life. So if you perform badly for the last 10 years, but now you're doing great, you will still look terrible because you've got 9/10 of your patients are still bad, right? While the vertical axis is current, so that's the last viral suppression, right? So the vertical axis keeps up with you. This one has this huge lag. So what you want to do in terms of a performance indicator on this one would be just to look for the last year. And this, I'm going to just zip through it, but it just, it just shows that, you know, the cost per patient, people always talk about this kind of cost. When you talk about what does it cost to treat a patient in Mexico, it's a little bit like what does it cost to do HIV testing on someone. It's the cost of the client that comes in the door. But in fact, our goal is not to put pills into people. Our goal is to keep people alive with the pills that we put into them. So looking at the cost per patient who's successfully treated is really what matters. And that's very different than the cost per patient treated. And the difference between those is performance, right? And this is just, for those of you, none of you actually work on TB, but one of the huge failures in anywhere in the world, and this is examples from Africa, is the fact that you've got people with HIV and people with TB, a huge amount of co-infection between the two diseases. And this is, of those people currently receiving treatment for antiretroviral therapy for HIV, what proportion of them are getting the other way around. Let me say the other way around, because it is the other way around on this graph. You can show the graph either way. Of those patients being treated for TB who are also HIV infected, what proportion of them are receiving treatment for their HIV infection? And you can see that it goes from Ghana and Cote d'Ivoire less than 40%, or actually Cote d'Ivoire is a little bit better. The Congo and Ghana down below 40%. No, even worse, Zimbabwe is terrible. All the way up to Angola, which is, well, they say 100%, but may not be quite that good.
I was wondering how, it was my impression that the protocols for treatment of HIV in TB patients has been changing a little bit because of IRIS and changing, which is the immune reconstitution inflammatory syndromes. For a while, they were delaying giving people antiretrovirals until they treated their TB so they wouldn't get a bad reaction. But I think they're not, is it true they're not doing that anymore?
Yeah.
Was that true in 2013? Or?
So,
How does it change the statistics of that?
well, at this level, if you're talking about a month or 2 month delay, I mean, there's debate about whether you should start simultaneously or whether you should wait 2 months till you start your antiretrovirals. This statistic would really not be significantly effective, right? Because over the course of the period of treatment, it should still be extremely high. And I don't know whether it's, well, and it even says among eligible. So if the protocol in the country says you wait a month or you wait 2 months, then this denominator here would not be all TB patients, it would be eligible patients. So in theory, they were correcting for that. I mean, this is mostly a reflection of the fact that TB programs and HIV programs sit in different places and see patients in different clinics, and patients are expected to shuttle back and forth and are not well coordinated. So instead of turning every HIV clinic in sub-Saharan Africa into an HIV and TB clinic and vice versa, people are still shoving patients back and forth. And what do you want to do for a patient with TB who's HIV infected? To treat their TB, you want to also treat their HIV. This is one of those very much no-brainer scenarios. So I was going to switch to the question of how the Gates Foundation thinks about how it invests in things, including diagnostics. Shall I? So what we did, that's where I was until recently, or relatively recently, so I came back a year and a half ago or something, or came down here. And so we said, well, how should we think about how to prioritize which investments are more worthy of money than others, right? And so the first question was, well, if we're successful, if we're investing in a new diagnostic or a new drug or a new vaccine or a new device, if we're successful, given what we think this product would cost and the conditions for which it's potentially utilized, what would be the cost per DALY averted? Everybody familiar with DALYs? Not much nodding. Disability adjusted life year. So, in other words, per measure of health gained, right? So it's like a year of life lost, except it's a disability adjusted year of life lost. And so that's the vertical axis. The vertical axis is the higher you are, the better the value. So high value, meaning low cost per DALY gain, and the bottom is low value. And then the horizontal axis, if you think about it as a drug developer or a device developer, is the probability of technical and regulatory success. That's PTRS, they talk about that in the industry all the time. So it's sort of saying if you're looking for a go, no-go decision on something, then you want to know how likely is this thing to succeed. Right? And this is, of course, not something where any particular drug or device, it's not static. So the vertical axis, you may think of it as static. If you get it, this is how much good it will do at what cost, right? But the horizontal axis, through the course of development, you can start with something that's very high risk on the left. It may be that small investments can move it to the right. It is as you pass hurdle after hurdle after hurdle, the probability of technical and regulatory success moves to the right, right? And in terms of thinking about whether you want to make investments, you're usually thinking about the vertical is where the thing is going to sit, unless somehow the characteristics change dramatically from what you thought. Cost goes up or goes down or whatever. The horizontal is what you're thinking about pushing the bubble to the right by investing in, passing one hurdle after the other. Some things you can invest a little to push it a little bit to the right. And some things you have to invest a lot because you can't push it a little bit to the right, you can only make big jumps. So what do I mean by that? If you're thinking about a point-of-care diagnostic, and you've got some magnetic bead technology that you're working on, and what you have to show is whether you can in fact get these beads to bind to the antigen, right? So you can invest $50,000 and figure out whether you can manage to make the beads bind to the antigen, and if you do, then you pass that hurdle and you move it a little bit to the right, and $50,000 buys you that, right? But if you've got an antigen, and you're hypothesizing that that antigen will cause somebody to produce antibodies that will protect them from HIV infection, a vaccine, then it's going to cost you $70 million to test that hypothesis, right? So there's a huge difference between whether you can spend a little bit of money to push progressively right on this PTRS versus some things where you have to make very big bets for what would then be a very big jump, right? So when you're thinking about these movements, that's important. Then the bubble size has to do with how big a difference would it make to the world if it happened. So something can be cost effective, okay? In other words, we could have something that's cost effective at reducing the symptoms of myasthenia gravis. So a relatively rare disease, even if we cured myasthenia gravis, the total number of dialysis in the world that we would affect would be relatively small because not very many people get it, right? But if we had something to cure diabetes, then the size of the bubble would be huge. Now, something could be cost-effective or not cost-effective for myasthenia, or it could be cost-effective or not cost-effective for diabetes. Whether it's cost-effective or not is whether it's high or low on the vertical scale. How big the problem that it addresses is how big it is, right? So if you're the foundation and you're talking about investing in the technology, you care not only about how cost-effective it is for every one used in the future, but also on whether the investment could pay off for lots of people or a few people, right? So from an investment perspective, both of them are relevant. If you end up creating a precision medicine technology that costs $10,000 per dialysis saved, then nobody will ever buy it, even if it addresses a massive population in the developing world. Similarly, if you invest $80 million to develop a vaccine for a disease that hardly anybody gets, then it's going to be a very poor return on investment. Right? Make sense? And finally, the blue is the coloring of what proportion of the cost somebody else will pay for. Because we're only being asked to pay for the cost that we have to pay for. So if it's a question of moving something to the right, and somebody else is picking up 80% of the cost, then for us, the investment decision is it worth the 20%, not is it worth the 100%, because somebody else has already made that. So these are basically the four input variables into a decision model. Now, obviously, to generate any one of those points, for example, the likely future cost effectiveness involves a bunch of work. But if you had those 4 points, then in theory, you can think of a decision model. And now, you might think, oh yeah, well, then I would imagine that what the foundation wants to do is to be in that upper green zone, right? You want to be investing where you think it's going to be really cost effective with big bubbles and where there's high likelihood of success. And the answer is, well, no. Any idea why you wouldn't want to be up there if you were the Gates Foundation?
Other people might be willing to fund those things.
Exactly, right? So once you get up in the upper right-hand corner, you can toss it to USAID, right? Because they'll take it forward. And NIH will take it forward before that, right? And the private sector will take some of them forward if there's potential economic return. So the role of the foundation is actually more in the upper left quadrant, which is the high-risk, high-reward space where the NIH or the private sector, the USAIDs, et cetera, may not want to play. Or potentially in the less cost-effective but very high impact, right? Because an investment could have an impact for a massive number of people, even if it wouldn't necessarily be such a good deal per person. So it's this trade-off of you want it to be both high in value and big in impact in terms of where you're going to prioritize those investments. And then what we actually did was to try to do that for the global health space. This was before the foundation divided, changed it the way it was organized. But we basically mapped our current investments onto this. And realized, of course, as we tried to do that it's more complicated than it seems. So that black bubble down there, which I tried to fix a few minutes ago, but I still can't reread it, is supposed to say $100 million averted. So remember I said the bubble size was related to what is the potential total impact in health that you could have with that investment. And my area was AIDS, and those are the brown bubbles. And so you can see way up at the top, it says pox protein with a brown bubble, and that's a vaccine. So if we had a vaccine with the characteristics that we expect to there, then you could imagine that it's not just cost effective, it's cost saving. So cost saving meaning that it reduces the costs more than it costs, right? So that it produces a net cost saving. You can't speak of cost effectiveness in the negative because it becomes sort of infinite cost per. I mean, I'm that's the wrong way to say it. If the cost to prevent or to prevent the loss of the dally is negative, it makes no sense. Let's put it that way. Down below, you can see some big brown bubbles. So the reason the pox protein up there is small is because that's a pox protein vaccine that we were working on then, and still are working on, which would only be relevant for sub-Saharan Africa, for southern and eastern Africa. So it doesn't have the ability to treat the whole world, because it would have to be a different vaccine to do that. Of course, it might make the next vaccine it might significantly improve the probability of technical and regulatory success for the successor vaccine for a different part of the world. And the ones down below that are big brown ones, you see passive immunization there. So passive immunization, meaning injecting antibodies into people, broadly neutralizing antibodies, sort of vaccinating them by injecting them with antibodies. Okay? Likelihood of success? Well, maybe better than that, but still very far away because it's an early technology, but at least scientifically very likely. Not very cost effective, whatever that is, $3,000 or something per dally. But big, because broadly neutralizing antibodies you can use anywhere in the world. Okay? And then over on the right, you see a dipivirine ring, and you see the TMC 278 is a drug approach to a long-acting injectable preventative drug that would also prevent infection. So all of those down below there are usable anywhere in the world, so in theory potentially addressing a very large population. But what complicates matters is that dipivirine ring, so a dipivirine ring is an antiretroviral containing vaginal ring. So not so different from diaphragm that people used to use for contraception. You put the ring in the vagina, it stays there, it releases dipivirine for 3 months and would prevent vaginal transmission of HIV to the woman, not necessarily the other way around, probably not. And why do I draw the bubbles above it? Well, because where it is, in terms of cost effectiveness, depends upon what population you're assuming it's going to be used in. So at the very top there, you can even imagine that if used in KwaZulu-Natal, the highest incidence, highest prevalence part of South Africa, dipivirine rings could actually be cost saving, even though they might be relatively expensive, because the incidence is so high. But if you use them in Morocco, then they're going to be extraordinarily expensive, $1 million per dipivirine ring, because the incidence of HIV is so low, especially among women. So that big one, the original ring, is the sort of global average cost effectiveness of dipivirine ring. But if you wanted to make it more cost effective, you could move it up. But then you have to make the ring smaller, because the ring's getting smaller because the population in which it's being used, or the disease burden that it's addressing, is smaller and smaller, right? So it turns out that you can, in a sense, decide where you go on the vertical axis for some of these things, especially infectious diseases, depending on the incidence of the problem, right? Not true for a therapeutic compound, Because a therapeutic compound, you're only treating people with the disease, right? So you don't have that same kind of enormous variability in cost effectiveness as you do with a preventative compound, where the incidence varies by multiple orders of magnitude from one geography to another, right? And the other thing, of course, is that each move to the right can be very different cost and very different distance. So when it was first put up there to show people, this was sort of the first version of the graph with neither of those things. And there was this sort of sense of, oh yeah, we want to be sort of in the, in that zone that I mentioned of, riskier or whatever. And I'm like, well, no, you don't actually know that. Because the question is, the question is that first yellow arrow worth it? Right? Because the question you're asking is, am I going to invest the next bolus in the development of that device? And that next bolus isn't continuous, right? Because in this case, we had an inhibiting ring, and we had to go to a phase 3 trial. So that was a big bolus. That's a $50 million investment to do an effectiveness or an efficacy trial of that ring, which the previous step was, does it pass the, does it elute the compound a sufficiently constant rate over the course of a month to be able to be a credible product, right? It's sort of, and that was a $100,000 investment. So each time you're asking, is it worth the next bump over, right? So in the case of passive immunization, now that's an interesting one in the vertical, because in theory that's where we decided to stick it in terms of cost effectiveness. But some people came along and said, well, people are looking at some process engineering on production of antibodies that could reduce the cost per kilogram of antibody produced by easily an order of magnitude. Well, and maybe 2. Well, what does that do to that bubble? It moves it 1 or 2 bumps up that log scale, right? And so, if you can have transformative technologies, yesterday I met with the VP at Gilead about tenofovir, and they were licensing it to India. They licensed it years ago to India, and their process folks, top process chemists in the world, they think, they said, well, they may be able to produce a generic, but they'll never do it more efficiently than we can because we're like the best around. Well, they produced it for 17% of what Gilead could produce. And it turns out that folks at places like Gilead are really good at figuring out how to do something. Folks in India are really good at figuring out how to re-engineer the process to make it cheap, because that's where they make their money. And the heads of most of the generic companies in India are process chemists. So each of those bubbles there for something that doesn't exist is making assumptions about production technologies and about where something is likely to be. So the example in the diagnostic space, so before I left, we made an investment in a company called Xiomix. Any of you run into it? They're here in the South Bay, although I was just reading yesterday the press releases of how they fired all but 6 of their employees and basically they're tanking. So what they did was they developed a point-of-care CD4 test. And it was one that was a bead-like visualization. It actually looked sort of like a mercury thermometer. You collected the blood sample, you mixed it up, and you spun it in this little hand crank centrifuge, then you picked up, and you could see little lines on it. There's actually a little tiny plastic lens in the device, which allows you to see the little lines, and you can read off the CD4 count. And it works. They'd come here to talk a year ago or something, I think. So the Gates Foundation put, I don't know, $15 million in, and Mylan, a big generic HIV drug producer, the biggest one that produces tenofovir, the Gilead drug, put another $12 million in or something. And at the end of last year, the foundation decided to pull the plug, despite the fact that it was successful. They decided to pull the plug. And I don't know the full reasons for it. I don't know whether some angel will come along and rescue them or not. But it had to do with the fact, not that the device didn't work, but with the fact that the market for that device was rapidly shrinking. And it was rapidly shrinking because people were increasingly moving toward non-conditional initiation of antiretroviral therapy and toward using viral load monitoring rather than CD4 count monitoring to gauge adequacy of therapy. So, and PIMA, the device that I showed you in the picture, which requires instrumentation and it requires at least battery power, but already was achieving significant penetration, even in Africa, of HIV clinics. So this question of what is that window of non-instrumented, sufficiently rural, non-electrified CD4 counts in a shrinking market as CD4 count becomes progressively less relevant, and the plug was pulled. So initially we made the case on the basis of this, and unfortunately I captured this graph before we put any of the diagnostics on it. So everything that's there is a drug or a vaccine or a device, because the diagnostics didn't get on it. But the same idea was, if we could bring CD4 counts to people rather than people to CD4 counts or samples to CD4 counts, then the number of people who would start early when they needed to start would be much greater, because you could basically take a CD4 count anywhere you could do an HIV test, and therefore you could identify who was eligible for therapy on the spot the same day and notify people of their eligibility, and the likelihood that they would then start therapy would be much greater than just being told the diagnosis and sent to some clinic somewhere for further follow-up. So, I don't know you remember this. So we're just about done, but I will show you one picture. So this is, no it isn't. That's wild. Oh, I see, we're on extended hang. Get the whole function of the there. So, duplicate. Left. There we go. So this is the global burden of disease. It's called Global Burden of Disease Compare, and this is the Institute for Health Metrics and Evaluation, IHME. So just go to their website. This is the website, and what you're looking at right here is basically a pie graph of the burden of disease of all diseases, actually not all diseases, communicable. So this is all diseases all over the world. The blue are basically chronic diseases, and the red are infectious and maternal and neonatal, and the green are injuries, accidents, homicides, suicides, poisonings, etc., drownings, etc. So this is what the world looks like. This is that's what Sweden looks like. So Sweden is overwhelmingly chronic disease, a little tiny bit of infections in maternal and neonatal, and some significant injuries. Fall there is going to be mostly the elderly, suicide and road injury. And if we looked at Mali, it would look really different. So you see these extraordinary differences from one place to another. LRI is lower respiratory infection here, diarrhea, meningitis, whooping cough, preterm birth, neonatal encephalitis, HIV, TB, malaria. If you look at, I don't know how we got to Somalia, but it ended up being the same. I thought I was typing Mali. If you go to South Africa, then not surprisingly HIV blows up. So South Africa wouldn't look nearly as bad. If you took HIV out of it, the blue would be bigger than the red. So it doesn't look like the poor countries in sub-Saharan Africa, except that it does because of HIV. Because HIV, and if you look at TB is actually surprisingly not bigger than that, it's just because HIV is so huge. But the other cool thing is that you can also look at it on a map. So this is HIV, and if we look at, anybody working on a diagnostic for Chagas? So Chagas disease is found in which region? It's found in the Americas. But it's very clever the way you can use this to look at what both the map looks like and zero in on any particular disease, zero in on any particular part of the world. There are other visualizations on the same website that allow you to look within some countries where they have actually within country data. So if you were focusing on the US, they have it at the level of counties. It's actually very cool, but nowhere near to this level of disaggregation by disease. So the other thing you can do is to take a look at not a map, but a stacked bar chart of risk factors. So here you see South Africa. So if I go to Sweden, you're going to see dietary risks, high blood pressure, high obesity, basically smoking, physical inactivity, and high fasting glucose are the top causes. If I go to Mali, Somalia again comes up, you see childhood underweight, suboptimal breastfeeding, household air pollution, cooking inside. Smoking is the first one that overlaps, iron deficiency, high blood pressure, unimproved water. Dietary risks is way down there. So extraordinary differences from one part of the world to another in terms of the risk factors. And if you're thinking about a diagnostic, so for one thing, I just pulled it up a few minutes ago, and I was amazed because it's wrong. At least it's wrong from what I know. And I'm going to go back and talk to these guys. But yesterday we were meeting with the folks from Gilead. And Gilead has this extraordinary blockbuster drug for hepatitis C. And the worst place in the world for hepatitis C, as far as I know, is Ethiopia. Now the one disadvantage of this visualization that I would like them to fix is that it uses the full dynamic range of the colors. So if you've got one country, and it's so small that it's not visible. I mean, I've actually tried to look for it. It's not Haiti, which is one possibility. It's not Papua New Guinea. It must be some little tiny country somewhere in the middle of the Pacific, because I can't see it. It will be dark red. And if it's, dark red is 100 on this scale, because that's the worst, then, and the next worst country is 40, then everything's going to be blue. So it's not great. That's the one flaw in this visualization.
I thought that Egypt was surprisingly bad with hepatitis.
That's why I say this is wrong. So Egypt is the worst in the world, and they've got 22 million people out of whatever it is, 110 or some million in Egypt, with hep C. It's the worst in the world. Gilead has got a major program there with a $900 treatment, which here is $84,000. And it doesn't show up right on the map. But if it did, if this was the right, so the hep B actually looks better. So hep B looks to me to be more believable, because there, I know that China and India are bad. But I think this is very clever if you're thinking about, you're working on different diagnostics and you're trying to think about how big is the bubble? What is the size of the population that I could potentially be affecting? And then you start to think about, for example, if we're talking about India, the proportion of the population with hepatitis B, who might be interested in a diagnostic, who needs a non-instrumented device because they don't have access to electricity, is very different than it is here in Mali. You know, so Mali may be a little lower prevalence, but here in Mozambique, for example, a much lower percentage of rural electrification than you have in India. So you could start to overlay some of the things which, so you don't get caught in the same place as I almost was, which is producing a very clever device that nobody wants. With that, I think we're out of time.
Thank you.
Any other questions or anything? Good. Thanks, you guys.